Good afternoon, everybody. Welcome to our latest session of the Matt Echo Clinic. My name is Danica Pierce. I'm a licensed clinical social worker, and I'm the MAT program coordinator at Northern Nevada Hopes. We'll take a few minutes to just kind of go around and introduce our team. And then following that, we would love to hear from each of you just a quick introduction about who you are, where you are, and what you're doing. So, you want to start?
Sure. Hi, Dr. Tracy Biondi, a physician at Northern Nevada Hopes with the Medication-Assisted Treatment Team. Welcome.
I'm Shalene. I'm representing the pharmacy for the
MAT team.
MAT team.
Dr. Mark Broadhead, addiction psychiatrist, VA Medical Center here in Reno.
Hi, I'm Kelly Memon, and I am the MAT case manager at Northern Nevada Hopes.
I'm Echo Troop. I'm an LCSW on the MAT team at Northern Nevada Hopes.
I'm Troy Jorgensen. I'm the program coordinator here for Project Echo Nevada. So we'll go around the group here and see who we have joining us. So Rick, you want to start us off?
Hi, my name's Rick Obringer. I'm a physician assistant, surgery-based, hospital-based.
Great. Thanks for joining us today, Rick.
Thank you.
And then another site signed on. It's HRHCTC. Could you introduce yourself?
Hi, my name is Brandy Whistler. I'm the Director of Integration and Population Health at Circle the City. We're a healthcare for the homeless provider, and we are just getting ready to pilot MAT.
Yay!
Excellent.
Where you at?
Yeah.
Great point. I'm in Phoenix, Arizona.
Okay,
Welcome.
welcome.
Excellent.
Thank
Great
you.
to have you today. And then we'll go to Austin. Austin, could you introduce yourself?
So my name's Austin Noriega. I'm a self-advocate in NV Lend, and you might hear some background noise. That's probably my son. But yeah, I'm very interested in learning more just so that I can. I'm from Fallon, Nevada.
Great. Great to have you today, Austin. Thanks.
Welcome.
And then we had another number join us, 157-757-3802. Are you there? Could you introduce yourself?
This is Kieran Madden. I just joined. I'm not sure if that's my number or not. So
Yeah, that's you.
That's not me. Oh, okay. So I'm the clinical director at the Indian Health Service Clinic in Elko, Nevada.
Great to have you back, Dr. Madden.
Welcome.
Thanks.
And then we'll go to Dan David. I think you're called in, Dan. Is that correct?
Yep, that's Dan David. I'm an RN care coordinator in Bishop. I have RN social worker, and we just got accepted for the ED Bridge grant, and so we are implementing a counselor in the emergency room, and we are implementing MAT psychiatry via telemedicine, hub and spoke with San Bernardino. So we're moving a lot of different pieces at the same time.
Very
Awesome.
cool.
Great to have you back today, Dan.
Thank you.
Then we'll go to Jennifer.
Hi, everyone. Jennifer Trujillo, Substance Use Disorder Program Manager at Nevada Primary Care Association.
Hi, Jennifer.
Hi, Jennifer. Good to have you back. Thanks.
Thank you.
And then Linda Christensen, could you introduce yourself?
Hi, I'm Linda Christensen. I'm an LCSW at the Rural Health Clinic here in Bishop, California, and I work with Dan David, who introduced him.
Okay, welcome.
Great, thanks, Linda. And then we have one other joined. It's Lori Squirtsoff. She doesn't have a microphone today. So we'll start it off, see if anybody has any questions they want to ask before we get going, or a particular patient case they want to discuss. So if you do, please feel free to take yourself off mute with the microphone icon in the lower left corner, or *6 if you're joined by phone, or use the chat function as well. So any specific questions or cases, we'd be open to hear those right now. Thanks. Dr. Madden, how are things going out there for you?
quiet.
Okay, well, it's open during the entire session, so feel free to, take yourself off mute, write in the chat function. We'd love to hear from you. So we'll get going here then.
Okay, so today we are gonna be talking about harm reduction. Just kind of talk a little bit about what that means. I'm not sure how familiar those of you in our audience today are with harm reduction. So this is just kind of a basic overview of what that means. So like Troy said, please feel free to jump in if you have questions during the presentation. You don't have to wait till the end. You know, for me personally, and I think for the rest of the team, we all kind of prefer to have it be more of a discussion than us just kind of droning on. So please don't hesitate to jump in at any time if you feel like you would like to. So our goals for today is to just kind of help everybody have a better understanding of what harm reduction is and what it is not. Harm reduction tends to sort of come along with some, what's the right word? Stigma is a good word. There are a lot of misunderstandings about what harm reduction means. And so we'll kind of try to differentiate that for you today about what it is and what it isn't. As part of the discussion today, we're going to talk about the stages of change. So for those of us who work in behavioral health, this is sort of, you know, a basic standard sort of educational piece that we get in our education and training. But for a lot of other folks, this is not necessarily something that you're learning or thinking about regularly. However, if you're working in addiction, it's incredibly important to understand. So we'll talk a little bit about that and about why our ability to kind of identify where an individual is in terms of their stage of change is really important for us to make decisions about their treatment, about what kind of treatment they need, and in terms of goals and things like that. It's really important for us to know where they are. And then, as always, we'll just kind of open it up for conversation at the end. So the definition of harm reduction, or at least the definition that I found that I like the most, is to reduce harm, obviously, stemming from health-related behaviors that are considered to put the affected individuals and or their communities at risk for negative consequences. So harm reduction is really about not only addressing the negative impact to the individual who's engaging in the behavior, but also to those around them. You know, harm reduction is really a public health, comes from the world of public health. So we're really looking at societal issues, community issues, family issues from the standpoint of treating an individual. So what we're really looking to do with harm reduction is improve quality of life. Again, not just for the individuals that we're working with, but also for those who they impact, which is all of us. Harm reduction is more of an attitude rather than a fixed set of rules and regulations. Harm reduction is very much about the gray area that exists in life and in some of these sort of complex issues that we're looking at. There is no black and white. And so it's really more about the way that it's a perspective. It's about the way that we're viewing the person, viewing the behaviors that is really sort of the foundation for harm reduction. So just in terms of like harm reduction in general, like these are a lot of things that just already exist in our world. Using sunscreen, for example, right? We're reducing harm, the harmful effects of sun exposure. Things like condoms, seat belts, wearing helmets. You know, these are all things that at some point didn't exist. And fortunately, we have people in the world who think about these things and who come up with ways to keep us all safer. So for today, we're going to be talking, you'll probably hear me mention a couple of times our needle exchange program, which we have at Northern Nevada Hopes. We're the only exchange program in Northern Nevada. And then obviously we'll be talking mostly about medication-assisted treatment. So any questions or comments so far? Just want to check in before we kind of get into the nitty-gritty. So if you really, did you have somebody?
No.
Okay. So if you really sort of, want to break it down, harm reduction you can break it into two major parts. One is having a compassionate stance, which is kind of that attitude that I mentioned before, but also pragmatic strategies. So in terms of taking a compassionate stance, what we're looking at is really just understanding that high-risk behaviors exist, right? They're going to be present, and for us to have a way to approach them that is respectful, that includes dignity, compassion, and is inclusive of the individuals affected by the behaviors. Again, not just the individuals, but sort of the broader community, which includes all of us. While holding that compassionate stance and sort of coming at it from that understanding in that place, we're also looking at pragmatic strategies. So we're looking at strategies that are going to reduce harm, looking at it through a lens of public health, and we're going to use accurate, fact-based education about, ultimately the consequences of drug use, right? Drug-related illness, injury. So looking really at it from like that public health scientific lens, but also doing it in a way that is respectful and compassionate. And I think we have a question.
Why do you think that you're the only organization to provide needle exchange? Is it stigma or regulations or protocols to implement?
That is a very good question. I don't know the answer to that, but I would say just sort of, speaking from my own, what I know, our needle exchange hasn't been around a super long time. I know that the process to be able to do that is not necessarily a simple one. There is a lot of stigma. Our program gets a lot of pushback from certain members of the community. I know in terms of our program, over the last year, 9 months to a year, we've made a lot of changes to the way that we operate. And part of that was because of some pushback from the community. So we've changed our program in several ways, and I think are a lot more efficient, and our practices have become sort of safer.
Can you talk about what those?
Sure, yeah. So we've implemented sort of stricter policies around how many needles individuals can get at a time. So depending on if they're new to the program versus if they've been using the program, the more consistent they are allowed access to a greater number of needles. They also are incentivized to return extra needles. So, for example, if they bring in more needles than they were given the last time, they get stuff. They get backpacks with hygiene products. They get gift cards for food. And so our return rate on our used syringes is over 100% right now. So we're getting more needles than we're giving, which I think is pretty fantastic. And I will say that I think all of us, I don't want to speak for all of us, but I think that for most of us, we all recognize that there are dangers associated with handing out needles in terms of them being out in the community. But we also know that, when you get back into the forest and you look at it from a public health perspective in terms of infectious disease, it is much safer. So, does anybody else have any comments on that?
Well, I would just say another thing that I don't know if you may or may not be aware of, but also the Change Point also goes out into the community and collects the dirty needles and picks them up and disposes of them properly, which is kind of an important aspect of what they do. And then sometimes people wonder, gee, a bit of a sensitive area, but are they allowed to use whatever their drug of choice is right then and there by shooting up on premises? And the answer to that is no, they're not. So for whatever that's worth, there are programs in Europe where they have sort of these safe. Yes. Okay. So, but that's not exactly that's not something that we condone. At least not right then and there when they pick up their needles.
I think one thing to highlight about needle exchange programs is needle exchange programs do not appear to increase the rate of intravenous drug abuse in the community. So having free access to needles doesn't make you more likely to switch from smoking your heroin to shooting your heroin. There are other drivers in that decision, mainly financial ones, and access to the drug. So it'd be one thing to say if we were giving away free heroin, that might not be the best thing to do. But exchanging clean needles is a pure harm reduction and does not, there's no evidence that it increases switching from one method of using drugs to using an IV.
And also, I think we're pretty fortunate at HOPES. For those of you who aren't familiar with HOPES, which I think probably a lot of you here today aren't, HOPES we're an integrated care clinic. So we provide primary care as well as several specialty programs, MAT being one of them. And our needle exchange, which is called Change Point, is on the same campus as our clinic. So we're working hard to really work on, making sure that individuals who are using our needle exchange services are being educated and offered opportunities to come over to the clinic and get into treatment. So I think we're pretty lucky to be set up that way. And that's something that is really a focus of ours is moving people towards treatment.
Austin, did you have a question or comment?
Oh, yes. I think you might be going into it here in just a moment, but has there been any data collected as far as, how many users have, transferred over to treatment going through the needle exchange program?
That's a really good question, and the answer right now is no. It's a relatively sort of new process that we're working on. Our MAT program hasn't been in existence for very long, and so we're sort of still in the process of getting more structure and things like that. So it's sort of a newer process for us to be engaging those participants that use our Change Point program. But it is definitely something that we're working on, is how to track that data.
Okay.
Thank
It'd
you.
definitely be very interesting to see in the future how much impact it could have.
Yes.
As far as harm reduction.
I agree. Any other questions? Okay, so we'll talk a little bit about harm reduction in terms of substance use. Harm reduction accepts that licit and illicit drug use, abuse, and dependence is part of our world. Right? There's unfortunately not any, at least anytime soon. We're not looking at a world where this isn't going to exist. And so the idea is that given that fact, that we're going to choose to work to minimize its harmful effects. So acknowledging that it's there, and then taking the steps that we can take to try to minimize the harm that is being done to individuals and communities. Harm reduction also understands that drug use, abuse, and dependence is a complex, multifaceted phenomenon that encompasses a continuum of behaviors. So, you know, we have people that are on one end of the spectrum who are, you know, functional in their use, to those on the other end who are, you know, very much struggling and tend to be high utilizers of our services, not just in, you know, in our medical services, but in terms of criminal justice system and things of that nature. And then also in the way that we use substances. So, you know, having, you know, one too many glasses of wine versus intravenous heroin use. There's this huge spectrum of addiction that we see. So we really have to acknowledge that that's the case and not try to treat everybody the same. There is no one treatment modality that works for everybody because of this continuum that exists. So harm reduction establishes the criteria for successful interventions and policies as the quality of individual and community life and well-being, not necessarily cessation of all drug use. So for some people who struggle with dependence of any sort of substance, they need to be abstinent. That is the only thing that works for them. But that's not the case for everybody. There are people that can significantly sort of reduce their use to the point where it's no longer creating the kinds of problems that it has at one point or another. You know, I think for most, not all, but for many people, you know, as we move through life and we experience the challenges and complexities of life, there are times where we tend to drink more or to watch more television or shop more. We all have our things, our vices that we use to kind of, you know, get through difficult times. And so that's sort of an important thing to keep in mind when we're thinking about, you know, how to treat people. That it's not just you can never use ever again. And again, for some people that is the case, but it's not the case for everybody. Harm reduction calls for non-judgmental and non-coercive treatment. What we're trying to do is invite and empower people to make decisions for themselves about, you know, their use and how it's impacting their life. I would say that for probably everybody here today, I think it's safe to say that none of us like to be told what we can and cannot do. And we also don't like to be coerced into doing things that we do or don't want to do. I think that's a pretty standard human experience. And for most of us, when we're told something, when we're told we have to do something, it's pretty natural to want to resist. And so having sort of this ability to provide services and resources in a way that is non-coercive and is non-judgmental is really much more conducive for better treatment outcomes. Harm reduction ensures that individuals and communities impacted by drug use, abuse, and dependence have a real voice in the creation of programs and policies designed to serve them. This is sort of especially true when working with individual patients or clients. You know, it's really important to allow patients or clients to feel like they're part of the process, and then that they get to choose, they get to, you know, have a say in their treatment. Again, because we all want that in all aspects of our life. Okay. Any comments, questions? Oh. Harm reduction also affirms the individuals themselves as the primary agents of reducing the harms of their drug use, and seeks to empower users to share information and support one another in strategies which meet their actual needs. So kind of reiterating what I was just saying is that, you know, they, if you can get a client's buy-in and help them to feel empowered, they are far more likely to stay engaged and far more likely to maintain sobriety or recovery in the long term. Harm reduction recognizes the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect people's vulnerability to and capacity for effectively dealing with substance-related harm. We cannot expect everybody in our programs to respond to treatment equally in the same ways, because all of these things listed here they're factors. We just have to have some awareness about this, that we can't take 10 people in a room and treat them the same and expect them to come out the same. It just doesn't work that way. That each individual person is going to move through their recovery process and through their treatment goals differently, because people are different. And it's sort of, I think, you know, it's our responsibility as providers to acknowledge this and to keep this always ever present in our minds when we're working with our folks.
So a question here from Dan. How did you educate your board of directors, front and back office staff, and other medical staff to discuss the stigma and get everyone on board?
That's a great question. Are you asking specifically like about our needle exchange program? Is that what you're asking about, or about Matt?
Go ahead, Dan.
Yeah, I'm basically asking because I'm going to be going to a board meeting and discussing. Are you able to hear me?
Yes. Yeah.
Oh, good. I see muted on my screen, so I wasn't sure if you could hear me. So I'm being asked to go to the board meeting and talk to the board members and bring up harm reduction and needle exchange, and also to my front office and back office staff, because they're having lots of questions about, well, you know, what happens when these people walk in the door, and what happens when, you know, what do we do with these particular patients? So I'm just wondering what kind of education that you're giving, because there's a multitude of clinical and clerical and security guards and all of that stuff needing to be educated on the stigma and what to do next.
Right. I'm so excited that you're here. This is great. This is why we do these clinics. So it's really good to have you, and thank you for asking. You know, I think in terms of our program, the history of our clinic, our clinic started out 8 years ago or something as originally it was a van that drove around town and provided medical care to people who were HIV positive. And so our whole history of our agency has very much always been one of harm reduction, of meeting people where they are, compassion, and our whole culture is very much in alignment with harm reduction. So I think we probably had a pretty easy time with that for our own staff. But I do know that I've had conversations like this one with others in town who don't necessarily have that luxury. And it's really a complex issue with, you know, oftentimes very sort of emotionally charged opinions on both sides. And so sort of the simple answer is tell stories. You know, people connect to human stories. And if you can bring some examples of how people have benefited in, you know, in other agencies or, you know, in your community, or if you have to borrow stories from us or from wherever, if you can bring sort of those human examples of, you know, here's a situation for this individual and what their life looked like, and then they had access to this kind of services, and here's what their life looks like now, and here's, you know, what you know, how it's impacted the people around them. Those are the things that I think people listen to and hear. One sort of great example that actually came out of Reno and became a national story is $1 Million Murray. I don't know if you're familiar with that, but it was a story that was written, I can't remember what paper it ran in or magazine or whatever it was, but the story is called $1 Million Murray, and it's about a man here in Reno who was a alcoholic, just chronically homeless on the streets, in and out of jail, in and out of the hospitals. And he's called $1 Million Murray because, you know, looking at his life and his treatment and his visits to jail and visits to the hospital cost taxpayers $1 million. And so that when that story came out, it sort of pushed this movement that's sort of commonly known as housing first, which is to provide people who are homeless, if you house them first and you get them off the streets and you get them safe from harm, that they're then more likely to engage in treatment and more likely to kind of turn their lives around, which is a movement that's sort of been a thing now for several years. So things like that where you can kind of show, how harm reduction can benefit the broader community are usually the better selling points.
Thank you for that. I just want to add, went to the ED Bridge MAT meeting up in Oakland, and several of the doctors got up and were talking, and they're part of the program, they're part of the implementation of the MAT, and the physicians got up and there's like 3 of them that got up and said, I'm having difficulty prescribing a medication to get you off of the heroin. I get all of your social things and the HIV and that kind of discussion, but part of the MAT thing that they were struggling with is, one, I'm going to give you a medication that's going to get you so you don't have the cravings and reduce your heroin drive, and then on the other hand, I'm going to give you needles to go ahead and inject and to go ahead and continue that. And it was a really kind of interesting dynamic discussion about obviously the stigma and what kind of comes with it. But these are clinicians, these are providers that are prescribing currently Suboxone and still have really mixed feelings about the service that they're giving, but then also providing this harm reduction, needle exchange, syringes, but then another hospital gets up and they're handing out packets of syringes and things to cook your heroin in, like to an extent that was kind of crazy. So that's why I bring it up, is I think there's the stigma. I'm going to go in front of a board of several that are not clinical, and they're going to hear, I want to give out needles to our patients. And I think being rural and being small, I don't want to say that we're in denial about what we have, but we're in denial about how much we have in this community. So that's why I appreciate your feedback. So thank you.
Dr. Madden, did you want to share some comments?
Can you hear me?
Yep.
Okay, great. So we're also small in Elko, small outpatient clinic, and we have worked, Johns Hopkins has a pediatric and integrated collaborative care movement that we've gone to meetings for, and a big piece of that is talking about trauma-informed care, and trying to get so we're just Indian Health, so most of our staff is Native, so from the same communities oftentimes that our patients are from. But I still think when you're talking about the difficulties, everything from the schedulers to the a lot of the staff feeling like, oh shoot, this is just somebody that we shouldn't spend a whole lot of time on, or they're struggling. And so just that stigma really is still a real thing, even though these are, social, they're from the same community. And so anyway, this pediatric integrated collaborative movement, we've been doing a lot of training, and we're trying to train everybody in our staff, which I know isn't easy for every place, but they have this whole curriculum that you can expose everybody in the staff to, that talks about the issues that kind of increase the risk of having these problems. And instead of looking at people like, they've got, oh, you have this problem and you're a problem, and it really tries to, and granted, I don't think it's 100%, but I think focusing more on what's happened to people, their historical trauma and familial issues and all that, and how that affects them, and that they are not a problem in themselves, but that they have things we can help them with. I think the goal anyway is that if we look at it from that different perspective and make it an ongoing attempt to, instead of saying what's wrong with them, say what happened to them. And so anyway, there's a lot of information on that trauma-informed care and the ACEs score, and how that affects what happens to people. And I think it really does change the perspective in the clinic, from, oh gosh, but more just how can we help people that are struggling with that. So anyway, I think that's been something we've been working on doing, knowing that that's it's always going to be a challenge, but I think if you can try and reiterate and have everybody trained that way, it can hopefully help reduce some of that, that this person's a problem perspective.
I love that you mentioned that trauma informed and the ACEs. I went to a training once where I learned that if you have more than 6 on your ACEs, your chances of becoming an IV drug user are 12,000% higher. So
yeah, that's not surprising, but it's and a lot of them are not not as bad as you would think. So a lot of them are a divorce in the family, or so it's really shocking. So in one of the videos we watched to educate people about it, showed there was a room full of behavioral health professionals, and there was nobody pointed out who was who, but they did their ACE scores in that meeting, and a huge percent of these functional professionals had high numbers of ACEs, and it reiterates that it's not a us and them thing. It's basically the whole community, and some people deal with those better than others, but it was really eye-opening, and I think hopefully over time it'll help us feel like we're a place that people will want to come, because they're not treated like they're second class. So
yeah, thank you. Dr. Broadhead, you looked like you were gonna say something.
Oh, I forgot it now.
Okay. Okay. All right. Anything else before I keep going? Okay.
Thanks.
And then who was that? Was it Dan that asked that first question?
Yeah.
So Dan, if you have more questions, or you want to talk about your meeting coming up further, you can just let us know.
I remember what it was now.
Oh, good.
It was, I think, Linda was also the one in Bishop, right? There's
yeah.
From Bishop. They may benefit from perusing the our first "What is Matt About" slide presentation. If we could send that to them. In there, you'll see some slides on what happens to the brain when you're using drugs, that I found to be very helpful in kind of destigmatizing some of the behavior. I think it's also important we realize that just with any type of ingrained unconscious biases, they're always there. It's not like we hit one presentation and, oh, gosh, I need to change my entire way I look about things. It's trying to build a kind of culture in your clinic where you're always looking for it. And if someone has a bias and it comes up, that they're not dunned about the head and shoulders and beaten and pilloried for it.
Right.
It's just kindly pointed out to them because we all have them. Just as the addiction is, well, from a harm reduction point of view, it is part of the human condition. So are biases part of the human condition, and we're trying to retrain people to have, to look for those certain biases in and around populations that we're dealing with. So sometimes looking at this is how the brain is different in these individuals from us. And wait a second, no, some of us have those same behaviors as well, is kind of important. When I've gone to boards, however, and talked about harm reduction, the only thing that really gets their attention is money. And so what I always push on them is that if I prevent one endocarditis, I've saved everybody $100,000 easy. If I've prevented 3 abscesses that have to be opened, lanced, drained, and packed in the emergency room and in clinics later on, I've saved tens of thousands of dollars. It's all a money game at that point in time. If you can convince them is that we're not going to legislate this behavior out of existence, but we can keep it from costing us money. And that way you don't have to go down the touchy, feel-good pathway for folks who are, they're about the money, but they will listen to dollars and cents, and that's something where there is some hard data on that harm reduction saves you money.
That is a great point. All right. Anything else? Okay. And so the last one on here is just that harm reduction really celebrates incremental change, right? We're looking for slow and steady progress because, as we know, incremental change is really more sustainable. And so that's really what we're looking for. Okay, so let's talk a little bit about what harm reduction is not. This is a real important one. Harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with drug use, abuse, and dependence. Harm reduction is not sort of this, and I think, critics of harm reduction sort of use this as a way to say that it's, that it isn't useful. To say that, oh, we're just a bunch of do-gooders and we don't think that drug use is really impacting, impacting our community. But that is so not the case. Like, we all recognize and acknowledge and see on a daily basis how scary and how dangerous and how damaging it can be for people and families and communities. Harm reduction is not theory driven, as many other sort of approaches are. Really what it is just fundamentally pragmatic. So really it's flexible. It allows for that gray area. It allows us to treat individuals individually, to create change for people based on where they are and based on their goals, rather than us coming from a theory that dictates where they should be and what they should be doing. Sort of also along those lines, it's not an assigned set of rules, regulations, or policies. We're not saying, you're walking into our doors and here's what we're going to do and this is how it's going to go. Again, it allows for that sort of pragmatic flexibility. This is another big one that gets really sticky for a lot of people, especially people who have been in the field for a long time. For many years, abstinence was kind of like the thing. It was believed that abstinence is the only way. And like I said earlier, for some people, abstinence is the only way. It's the only thing that works for them. And for people who struggle with addiction, oftentimes it takes a lot of falling down and getting back up to find out that that's true for them. Part of that recovery process is, okay, I'm doing really great, things are going really well, now I'm safe and I can have just one. And they have to do that several times before they realize that that's not going to work for them. But again, it's not the case for everybody. There are plenty of people who struggle with addiction who can reduce their use and reduce the risky behaviors associated with their use and live productive and functional lives. And so harm reduction is not a replacement for abstinence-based goals or abstinence-based programs. They can both exist, they can coexist peacefully, and that it really comes down to what works for the individual, not as sort of a philosophical, this is how we're going to do this. Harm reduction does not mean that the client or patient is allowed to make all the decisions and or do whatever they want. Harm reduction isn't like patient walks in and says, here's what I'm going to do and here's how I'm going to do it, and you're going to, play along. That doesn't work either. There's absolutely a very important role for us as providers, with the knowledge and education and training and skills that we have to help people make decisions for themselves. Especially people who are in early recovery, their brains are all hijacked, they're not thinking clearly, their prefrontal cortex is shut down, they're not making good decisions for themselves. And, that is where we can step in and say, no, this is my expertise. And here's what I think will work for you. But it's a relationship. It's about building a relationship, building trust, building rapport. It's a give and take. And as that relationship sort of becomes stronger and, our patients or clients are more bought into their treatment and they trust us and they feel like we are compassionate and that we have their best interest at heart, that we want them to be successful, it gives us way more ability to call them out and to say, I hear you saying this, but I see you doing this. And that is really where the change, the long-term sustainable change is made, is sort of helping them see over time, gently and with their buy-in, how and why their choices are not serving them. Questions or comments?
Am I talking to you guys right now? I am. So I'm probably the greenest one in the room here. This is Hallie Vickers. I work over here with Dan David and Bishop.
Okay.
And I have a question sort of related to the abstinence-based goals. And again, really new to this, and there's a lot that's muddy for me. But I have a couple of patients. One of them is expired at this point. Another one I talked to pretty extensively yesterday, and he considers himself to be fairly successful. He's 6 months clean of a 10-year heroin habit, but he does drink and use cocaine recreationally. And he discussed with me that there's a big difference for him being at a party with normal people, as he described, drinking and using some cocaine as opposed to smoking meth or using heroin at 8 o'clock on a Monday morning. And he is leading a fairly functional life at this point. I don't know where that falls into, like how I'm supposed to respond or guide or lead or do anything related to that. And related to that discussion, I had a patient who died, and his thought was that he needed to smoke marijuana to stave off his heroin cravings. That's kind of a broad subject, but do you guys have thoughts?
Well, I have plenty. I'm sure Dr. Brennan has plenty too. Go ahead, Dr. B.
well, you take them where they're at. So the guy who's fallen into the glamour lifestyle of drinking and using cocaine, it's like, well, good on you. You know, you've taken a step up. You're no longer smoking the meth. You're no longer using the heroin. That's good. Let me give you some information that makes me concerned, and we should just keep an eye on this. And then we talk about the fact that someone who's had an addiction, their brain is set up differently, certainly now, if it wasn't beforehand, that they're going to be more susceptible to addictions to other drugs, because that's really what we're talking about here. We're just kind of changing deck chairs on the Titanic. That's our big fear, of course. And maybe 8 times out of 10 it's realized that they start getting into problems with those other drugs as well. But now is a perfect time, while he's still basking in the glow of coming off this other thing, that you give him kudos for doing that, and you say, and how will we know if this becomes another problem? So we begin to plan for the what ifs instead of waiting for the train to come along and hit him. How will we know when there's a train on the track and you're possibly in trouble? So the good housekeeping seal of approval isn't given for changing from one drug to another, but at least there's change. Now
his comment related to that was, I had a problem with heroin and methamphetamines. He said he could take or leave the cocaine. It wasn't really something that attracted him. He could do it once a few months. But what you're kind of saying is it really does set him up. And so, yeah, I think what you're saying makes sense.
And it may not come along for a month, 6 months, 9 months, 12 months, but putting something in place just so that he's aware of, and you've kind of discussed already, hey, and if it gets to X, and you and he can decide what X is, whether if I start smoking the cocaine, now I've got a problem, or I use it more times than not, I've got a problem, or I spend more than 20% of my paycheck on it, now I've got a problem. Doing that in advance, and what we're going to do about it if that should occur can be really helpful when that day comes.
Great. And the other patient with the marijuana. So again, this is all kind of new. He was on probation and getting tested. He wanted to have Marinol prescribed. I think he really wanted to be able to pee and be tested for THC and be okay. But he said when he used to use THC, and this was interesting, THC is in your system a lot longer, and he said he went to heroin or opiates initially because they're out of your system quicker. He was on probation when that happened, and that was where his habits started. So he started with marijuana, went to opiates because he could use it and pee cleaner faster. But he thought if he could use marijuana and be tested for that and it be okay, that he could stay away from heroin. What do you think about that?
Well, I'd ask him, because, well, wait a second. You were having a problem with the cannabis, and then you went to heroin. Then you started having problems with the heroin, so now you want to go back to the cannabis. What's changed that you won't have problems with your cannabis again? What you're asking us to do, and from a harm reduction point of view, would be saying, wait a second here, this is where you can't do whatever you want. Now, what you want to do is be able to use without any consequences. And that's not necessarily clinically indicated. Or you may think it is, but if you don't think it's clinically indicated for him to have a medical marijuana card, then we don't go down that rabbit hole.
Great, thanks.
Yeah, because the marijuana maintenance program generally doesn't work out too well.
Gotcha.
Yeah. I would just agree with, didn't really say anything I wasn't thinking, so I defer to you.
Should say better though.
No, that is so not true. I think one thing, that's, nothing about this is easy. You know, doing this work is so flippin' hard. And this is exactly why, because, you know, on the one hand, you know, we believe that clients have a right to self-determination. It's their life. You know, they get to make choices for themselves, and yet their choices obviously are impacting people around them. And so it's so difficult to kind of do that dance of, you know, allowing them to be involved in the process, because ultimately that's going to be the most effective in the long term, and also balance that with what we know is healthy and, you know, is going to make them better. It's really difficult work. And so just being able to, which is a totally different topic that we've done and we'll do again, is, you know, being able to sort of acknowledge that for ourselves and, you know, have good self-care and not get super tied up in, you know, our own sort of countertransference. It's very difficult to be compassionate and sort of hold that stance, and also watch people fail and watch people die. It's hard work. And so it's just important to be mindful that that's the case and to take care of ourselves.
One other thing I just wanted to mention along the lines of the marijuana, I come across that a lot in our patient population. People will often tell me, hey, you know, this is great, I'm doing so well, I haven't been using any heroin, I'm just smoking a little marijuana, what's the big deal? And, you know, right, you know, people tend to think, well, it's legal now in the state of California and the state of Nevada, isn't that terrific? And I think that all those things that you mentioned are true, and there are other things too that I like to tell people that a lot of people are not aware of, that there are, you know, there are consequences of that. I mean, we know research has shown that it disrupts your sleep-wake cycles. We know that to be true. We know that, you know, there are gastrointestinal side effects that are a consequence of long-term marijuana use. We know that it can be difficult to quit. People think, oh, it's not a big deal, it's not addictive. Well, that's not necessarily true. This can be a very, very difficult thing to stop doing. And so, you know, all those things are true, and there are other consequences that people, I think, are not aware of, especially in a brain that's already, you know, been proven to have a problem with addiction and drug abuse. So I try to make that clear.
Mm-hmm. And I think, you know, in terms of that and sort of moving people forward, right, going from 10 years of IV heroin and meth use to alcohol and cocaine sometimes, obviously a huge step, and still room for growth. Right. And there's always going to be, whether they're ready to acknowledge it today or next week or 5 years from now, there are always consequences on one level or another, right? Drinking once a month at a party, you're probably gonna have a hangover the next day. And while that is not, you know, the same like weight of a consequence as IV heroin use is, it's still a consequence, and it's still an opportunity for us to sort of empower them and motivate them to be able to kind of identify, like, I don't want to feel crappy the next day, or I don't want to not be able to sleep, or I don't want my wife to be pissed at me because I drank again. You know, whatever the consequences are, they always exist. And it's just sort of moving them along that path to notice and to get, to continue to sort of minimize their consequences, whatever they may be.
So I love the idea of kind of having a plan set up. The harm reduction with the patient that was drinking, using Coke, was he had been involved with a program called Bright Heart Health, and he moved to us based on their response to his drinking. They needed him to be abstinent entirely, and so he just ditched their program. And I kind of worry that, you know, kind of aggressively pursuing that would cause him to move along from another program.
Yeah, I think you're right. Two things to keep in mind that may have something to do with this particular case, probably more like the one with the marijuana, though. Is, I mean, a harm reduction points of view fits very well with motivational enhancement therapies. And that's basically what you're doing here is, so you can say, good on you, you got the needle out of your arm, your risk for hep C and endocarditis has dropped massively. That's great. How are you doing in terms of establishing the things that you want? Okay, you've reduced the things that you don't want. You don't want endocarditis. You don't want to be thrown into jail. You don't want all of these other things, and you've done that. But where are you going? Where do you want to go? So again, getting them from a motivational enhancement point of view to say, and where do you want to go to? And will allow you to episodically bring up, and how's this working to get you there? So, I mean, it's one thing to keep you from the bad things that you don't want, but is it at some point in time going to be interfering with your ability to move forward? And in what other ways can we get you moving forward? So that's one approach. It's kind of a mind shift, you know, on them. The other thing from a consequences point of view, specifically with buprenorphine, in the buprenorphine clinic at the VA, you know, it's a federal facility. We're supposed to not have these people using illicit drugs, and from the veterans' perspective, it's still a illicit drug. But I'll let them stay because of a harm reduction approach. But there's consequences. They have to come in weekly for their medications. That's the consequence. And they seem to understand that, hey, I can't just give you this while you're still using drugs. We got to keep a close eye on you. The only reason you can get a 2 weeks, a month, a 3-month supply of medications is because you're meeting these certain standards. Not there yet? Well, we'll still keep you in the program, but here's where we have to keep you. And we've got a guy who's coming in from, you know, basically out of state. He's got to drive long ways. It's taken him 1.5 years, but finally he's come to the point where the rest of his life is doing so well, he's saying, this is a pain in my butt. I quit cannabis simply because I don't want to come in every week. I've got other things I want to do. So there are ways to kind of help craft your consequences that aren't so dire for their particular using, but over a period of time, if we believe their life is getting better, they're going to see this as being an impediment, and they're going to make, at that point in time, they're going to be willing to make those changes.
Awesome. I loved all of that good practical input. Positive reinforcement. Thank you.
And Hallie, I would say, and for everybody, if you're doing this work and you aren't familiar with motivational interviewing, get familiar with motivational interviewing. Like step 1, first thing on your to-do list is get trained in motivational enhancement. Is sort of like a the philosophy, but a motivational interviewing is sort of the theories, the training. That should be sort of at the top of your to-do list, because really it will give you all of the language and all of the skills that you need to do this work.
And to that extent, I don't know if y'all are familiar with Project Match, which was a long-term, big study on alcohol use disorders, and they used 3 different arms. One of them was a 12-step motivation arm, a cognitive behavioral treatment arm, and a motivational enhancement arm in their study, the results of which are not necessarily applicable here, but they have manuals, the program manuals, the 12-week manuals that people would go through, and it's a great how to do it. Things that you can actually get from SAMHSA. I still think they're free. And you can get one for the 12-step facilitation, motivational enhancement, and that combined with another workbook for cognitive behavioral therapy. Real good practical ideas for sessions that you can use that deal with various and sundry issues that come up in substance use disorders.
Do you know if harm reduction materials, needles, and information are provided to people when they're released from jail?
No, not currently. We do have a relationship with the jail, and we do have a program where we take people who are being released, and we bring them in and we do some basic physical and try to get them connected into services, just as a method to reduce recidivism. But in terms of the actual needle exchange, we do not do that, and my only sort of suspicion around why we don't do that is that law enforcement is not particularly keen on needle exchange because they get poked. Law enforcement is sort of one area that really tends to have a harder time because it impacts their safety because they're dealing with these folks in challenging ways. So not something that we do currently, not something that's necessarily like not doable, but that's sort of my understanding of that, which we're working on, by the way. Okay, I'm gonna keep going and then we'll have more time to talk. Did I get through all these? That's so long ago. Okay, yeah. Okay. All right, so just gonna talk a little bit about cycle of change or stages of change. I don't know how familiar our audience is with this, but this is sort of, like I mentioned earlier, sort of, social work 101 or drug and alcohol counselor 101. This is the model, and there are lots of different graphics that are used. I just like this one. This is what we look at when we're sitting with a client and trying to kind of determine where they are in terms of their change process, so that then we can make decisions about where to place them in treatment and what kind of treatment goals they need. So if you look at the top bubble that says pre-contemplation, that's sort of number one, typically. It's a cycle, obviously. But that's sort of where it starts. And what that is that's where I don't have a problem. They've got no intention of changing their behavior because there's no reason to change it. A lot of times these are folks that are just got out of jail and mandated to treatment, right? They show up in our office and they're like, I don't know why I'm here. This is stupid. I don't want to do this. I don't have a problem. So our pre-contemplation folks are challenging, especially if they don't want to be there, if they're mandated. Typically, if they're coming to see us for treatment and they're not mandated, they're probably not in pre-contemplation unless they're getting coerced by a family member. But even at that point, sometimes there's some contemplation because they're showing up. So after pre-contemplation, people tend to move into contemplation, where they're starting to notice that maybe their use is getting in the way of something or other. Maybe it's, mom and dad took away their phone, right? Or maybe it's my wife is really upset with me all of the time, or I got fired from my job, or whatever it is. They've started to experience some sort of consequences, but not necessarily wanting to do anything about it yet. Once they get to the point where they're like, okay, maybe I should do something, is where they move into the preparation stage. So they might be thinking about it. They might get a brochure from somewhere. They might talk to their doctor. They might talk to a friend. So they're starting to kind of look into, okay, maybe I could do something, or maybe I need to understand this better. Once they've taken action, they've taken a step to do something different, is when they move into action stage. So they're starting to kind of go through the motions of changing behavior. And then once they've done that for a period of time, they move into maintenance. So this is where they're starting to just kind of replace their old behaviors with new behaviors. They're going along, they're in active recovery. And then we have relapse. So you'll often hear us say, us meaning providers or people who work in the field, that relapse is part of recovery. And no, that is not an excuse to use or an excuse to relapse. What that means is that every time somebody has a relapse, it's an opportunity for learning, it's an opportunity for growth. So what we're looking for in a recovery process is we're looking for those relapses to be less often and shorter duration. So rather than relapsing and going back out and using for 6 months before I, move back into contemplation, preparation, action, what we're looking for is for a relapse and then 3 days later they call their sponsor, or 3 days later they show up for therapy. That's what we're looking for. We're looking for that process of growth and change. It's extremely rare to have somebody go through these phases and get to maintenance and never use again. It's just not very common. And if you can all kind of like just take a moment and think about your own lives and think about a change process that you have been through or experienced, I mean, this applies to all kinds of change. This isn't just about recovery. I very much struggle with this with yoga. Yoga is very important to me, and when I'm in it and I'm active in my yoga, I'm in maintenance, but then I stop going, right? And life gets in the way and we get busy and I'm like, I don't need to go. And I move through this with that. And this applies to all of us in lots of different ways. Maybe it's like, I don't want to yell at my kids all the time. You're going to go through this same process. I don't want to fight with my partner. You're going to go through the same process. This change process applies to all kinds of change. So any other comments about this or questions?
I thought you were going to say yogurt.
Frozen yogurt also applies to this. Yeah. So the reason why, well, there are many reasons, but why this is so incredibly important is that if you have somebody coming to see you and they are in pre-contemplation, the conversation that you're going to have with them in that moment is entirely different than it's going to be if they're in action. It's not the same conversation. And if you try to have the same conversation with somebody in pre-contemplation as in action, your pre-contemplation person is going to walk away and never come back. So you really have to be able to identify where they are so that you can tailor your language and tailor your conversation and tailor your treatment goals to where they are. Otherwise, you will lose them.
And this is the essence behind motivational enhancement therapy as well, is helping them through pre-contemplation and contemplation. Some of the other techniques can be more effective and actually become more useful later on in the whole process. But just getting them to come and then to come to the motivational enhancement techniques are much better at, and they feel a lot more comfortable for the therapist as well.
Yeah, Hallie just made a comment on the chat about the upward spiral, which not all the graphic models have that, and that's exactly why I like this one. Because that upward spiral is so important because that's how they learn. So when they come back from a relapse and they can identify that, oh, yeah, before I had this last relapse, X, Y, and Z was going on. And I didn't, they don't necessarily have that awareness the first time. And then they can say, oh, so this was going on. I had an argument with so-and-so, or I drove by my dealer's house. Whatever it is, they can recognize and say, okay, that didn't work. I don't want to do that again. So that upward spiral is why I like this one, and I think it's just so crucial kind of understanding how this works. Okay, so here's sort of like, I think if we just kind of tie all this together, our conversation, these are kind of the most important things in my mind, is that we have to start where the patient is. So in terms of that, the stages of change, knowing where they are and starting there, and not setting expectations for them when they're not ready, because then they will fail, and then that failure will continue to sort of exacerbate the very essence of the problem. So harm reduction is an umbrella concept that must be linked with a full range of therapeutic interventions. Harm reduction is like a philosophy. It's that sort of compassionate stance, pragmatic strategies. It's the way that we kind of look at the problem, but the nuts and bolts of it, you know, are other things. So we got to look at sort of that whole range. The onus is on providers for us to decide how to reach our patients. Going back to something that Dr. Broadhead said earlier about helping them identify what they're moving towards rather than what they're moving away from. You know, moving away from is important, right? Moving away from IV use or whatever the case may be is important, but equally and quite frankly, probably more important is moving them towards something. So it's part of that, you know, our relationship with patients and the importance of sort of building that trusting relationships is that gives us opportunity to identify our client's value system, find out what is important to them and what motivates them, what drives them. And in the conversations that we have with them, that's where we're sort of learning about them. We're learning about what like gives them that fire in their belly, or, you know, the people in their lives that are important, so that we can use those things as motivation for them to move towards. Treatment goals have to be developed between patients and providers that focus on decreasing risky behaviors. And again, decreasing risky behaviors and also moving them towards. It is the therapeutic alliance that anchors patients in the treatment process. So super duper important. I think this is the most important piece. Patients come back to treatment because they feel heard, they feel understood, they feel like we care about them, they feel like they can get better. Many times when people come in for treatment after struggling with addiction for some time, they tend to be hopeless. They don't think that things can be better. And so their ability to continue to come back to an environment where they feel like we care about them, they feel like we want them to be successful, they feel like we're giving them the tools to do that, that's why they keep coming back. And so just really important to always sort of keep that in mind, that the way that we treat them and the way that we sort of honor the relationship that we have with them is really what helps people be successful long term. I think that's the last one. Yes.
All right, so we've got quite a few minutes left, 5 or 6 for questions or comments. So please feel free to write in or take yourself off mute.
Well, we really appreciate you guys all being here today.
Yeah, this was really good discussion and interaction from everyone, so thank you.
When's our next one?
Yeah.
Next one is March 13th. Let me figure out what we're going to do.
We're going to be talking about nuts and bolts. So our next clinic on the 13th is going to really kind of look at how to actually run a MAT clinic. So for those of you who are kind of looking at doing that, we're going to talk about like what it actually looks like when a patient shows up for an appointment, at least in our clinic, you know, every clinic is going to be a little bit different, but we thought it would be helpful if we kind of explained, like, you know, from a time a patient calls and is interested in a MAT program through sort of their treatment process and what that actually looks like in terms of scheduling and drug testing and all the things that we do. We're going to kind of walk through that process just to help give you some ideas of what is possible. And again, you know, different clinics do it differently, and ours isn't necessarily the only right way or the best way, but that's what we're going to be talking about. So we'd love to see you there.
Does that feel like something that you guys would like to hear about?
Good question. They're all like, I don't care about that. I'll be there.
Hi, this is Brandy with Circle the City. I mentioned that we're getting ready to pilot Matt, so I'm very interested. I put it on my calendar, and one or two of us will definitely be present for that. Thank you for today as well. This was helpful.
Okay, and with that being said, you know, please feel free to come with like some questions, because, you know, we want to be able to be helpful. So if we're just talking about the way we do our clinic and it like totally won't work for the way that you're set up, like we don't want to go on and on about something that's not going to be helpful for you. You know, we are an integrated care clinic, so we sort of have it easier in some ways than a lot of other places do. So we want to make sure that we're tailoring it as best as possible to be, you know, to be effective and helpful for you. So please let us know how we can do that.
I'm sure I'll have plenty of questions along the way as we dig in. We're also integrated care, so I'm glad to hear you say that that's easier.
Cool. Yeah.
All right, thank you so much, everyone.
All right. Hasta la vista.